to all of you for coming to watch this afternoon session. We have two 1-hour sessions, the 45-minute sessions this afternoon. And I just want to go ahead and start. I'm going to give an introduction to our first speaker. First speaker is Associate Professor Ashley Bean. Dr. Bean is an emergency physician and a faculty at the University of Arkansas for Medical Sciences. She has an adjunct faculty appointment in the Division of Academic Affairs in the Office of Global Health, and she's a member of the Division of Emergency Ultrasound. Dr. Bean's talk will be about end-of-the-road ultrasound. So it's my pleasure to introduce Ashley Bean.
Thank you. So this is a great privilege today to talk about the value of ultrasound in low-resource settings. My objective today is to simply convince you that ultrasound is an incredibly cost-effective tool for improving healthcare in low-resource settings. It has several advantages. It's safe, it's portable and easily installed, it's inexpensive when compared to other imaging modalities, it provides rapid and timely knowledge, and it can be used by a variety of healthcare people in a variety of healthcare settings. The largest advantage is that it has a very wide array of clinical applications, and I'm just going to touch on some of those later on during the lecture. When I'm talking about ultrasound, I'm talking about goal-directed ultrasound that asks a specific question. Is there a baby in the uterus? Is there blood in the abdomen? This is ultrasound that's performed at the bedside by the clinician taking care of the patient. So the first advantage, ultrasound is safe. After decades of use, there has been no known instance of human injury due to diagnostic ultrasound. We're done with point one. So ultrasound is portable and easily installed. Here's a conventional X-ray setup. It's not portable. It requires quite a bit of infrastructure to be able to use this X-ray setup. Same thing with a CT scanner. Ultrasound is portable. When you reach the end of the road, but you haven't reached the end of your journey, you can put the ultrasound in a backpack or in your canoe and continue on. When speaking relative to other diagnostic imaging modalities, ultrasound is cheap. The main capital expenditure is, of course, your ultrasound machine. These portable machines cost somewhere between $25,000 and $75,000, although there can be some refurbished machines available for about $5,000. And as far as repair costs, bringing a technician in is sometimes quite expensive, and so you can actually just pick up the handle, pack it in a box, and send it to the company or to a technician somewhere. The operating costs, you have to have electricity for this to work. It does require only a simple power supply and can even run on battery power. If you choose to store the image, you have to pay for some type of storage device. This can be a flash drive, a thermal printer, or DVD. The main ongoing operating cost is going to be the ultrasound gel, and that's less than $10 a liter, and you only need a few ounces for each exam. The fantastic thing is that there are actually some local substitutes that can be used, so you don't even have to buy the ultrasound gel. Local oils can be used, and then there's a recipe where you can make ultrasound gel from cornstarch. Furthermore, ultrasound can be used in a variety of healthcare settings. These authors looked at the impact of introducing ultrasound in rural Rwanda, and they found out that ultrasound training changed patient management, that the program was sustainable, and that the reads were accurate. In addition, ultrasound can provide rapid and timely knowledge. This lady comes into clinic, and I perform an ultrasound, and she's happy and takes a picture of her beautiful child. On the other hand, this patient comes in, and we see this. So this is a molar pregnancy, and it's actually can become a rare form of cancer, and this lady needs to be referred to a specialist. Ultrasound can also be used by a wide variety of healthcare providers. It's not just for radiologists. So surgeons and critical care doctors and even eye doctors use ultrasound. The great thing about being an emergency physician is I get to do all of this. So physician-performed ultrasound. You say that's great if you work in the United States, where there are over 5,000 physicians working per 100,000 people. But what if you work here in Uganda, where there's less than 1/100th of that physician workforce? So these authors, including someone who's at the table here, looked at point-of-care ultrasound and training for non-physician clinicians in resource-limited emergency departments. And they found it was teachable, sustainable, it changed management. And here is my most important point. Ultrasound can be used for a wide range of clinical applications. We've touched on this topic already of the top 10 leading causes of death. And what I'm going to show you is how ultrasound can diagnose the disease, determine the severity, or identify complications of all these causes of death. Ischemic heart disease can cause congestive heart failure. A stroke can be caused by carotid artery occlusion. COPD or asthma can be recognized by these characteristic repeating A lines on ultrasound. Lower respiratory tract infections look like this pneumonia, and lung cancers can look like this lung mass. People with AIDS have a higher percentage of extrapulmonary tuberculosis, which can be suggested by this enlarged lymph node. Diarrheal diseases are very common, and you can assess your patient's volume status by looking at the inferior vena cava. Infections like this abscess are a common complication of diabetes, and ultrasound can show you the extent and the depth of the abscess. Road injuries, over 90% of road traffic deaths occur in low and middle income countries. And the patient who comes in and has blood in their abdomen, you know that person needs to be referred to a surgeon rapidly. And finally, a common cause of hypertension, a common complication of hypertension is aortic dissection, as is seen here. So in conclusion, ultrasound machines are safe, portable, easily installed, and relatively inexpensive. Goal-directed bedside ultrasound can be taught to those healthcare providers that are in the front lines of providing patient care. And ultrasound imaging can help diagnose a wide range of diseases or disease complications, including those on the top 10 leading causes of death. Thank you.
Our second speaker is Dr. Camilo Gutierrez. Dr. Gutierrez is a pediatric emergency medicine specialist who is working at Boston Medical Center at the Boston University School of Medicine. He's deeply involved in pediatric emergency medicine development as a subspecialty in other countries and is an active member of multiple American and international societies of emergency medicine and physician societies. His talk today is on the topic of medical simulation training in national and global healthcare arena. Is it here to stay? Dr. Gutierrez.
Thank you. It's a pleasure to be here to speak to you today. Like Terry mentioned, my background is pediatrics and pediatric emergency medicine, and I work at Boston University, and I have the pleasure to travel with some of my colleagues and friends to talk about developing acute care systems with emphasis on pediatrics, which is what I do. When you talk about medical simulation, just do a Google search, and you get more than 2,400,000 clicks results on medical simulation. And you can just go deeper and deeper and deeper and see how much simulation has grown in the last number of decades in the country for teaching in the medical fields. There's this publication back in 2011 by the American Academy of Medical Colleges, and they surveyed over 170 medical schools, and they found some of this, and also academic centers. And they found this, over 80 to 90% of the programs are using some level of simulation with their students. And this as well with residents. In postgraduate training, there's high levels of simulation. Around 80 to 90% of the programs that were interviewed has some kind of simulation. Not only in medical training, but in a lot of other allied health sciences, simulation has taken a major role in development. And these are some of the things that we look for in simulation. I don't have a pointer, but you can look at medical knowledge, at patient care. Communication skill is a key thing that we look for. There's practice, leadership, team training. So simulation has indeed become a strong instrument to measure these things. Like anything else, simulation is there's different aspects, and it's a learning curve for different ways. In some places of the country, simulation has really been driven by the most talented and expert physicians. And there's places like in Boston Children's Hospital and Harvard where there's sim lab. They're doing amazing technology, using 3D images to reconstruct real anatomy of patients from MRIs and CAT scans. And they actually have built exactly similar OR suites in which they will perform their surgery on a 3D model of the exact anatomy of the patient before they go in and operate the patient. So they actually can see the exact anatomy they're going to find when they go in on the patient. And this has driven a big change in how they do cranial, central nervous system surgery and congenital heart disease surgery. On the other hand, also, there's the learning curve and simulation is similar to the learning curve in everything else. Our residents in Boston University, we have our own sim center, and I'll show you here some pictures of our residents where they are training on our sim center how to assess patients, how to do ultrasound, Dr. Bean spoke, how to do procedures in these patients. And the virtue of simulation is that you can practice these events. They're not very common, like arrests in kids and all those things, but they have a high morbidity and a high mortality, and we just don't see them that often. So this is a way that we can prepare residents to manage these patients. And furthermore, what we really want to do is bring the simulation, and what, for example, our colleagues in PACE in Mexico have done. This is a picture in Kenya, it's a different group. But there's all these pictures in Mexico when we're teaching the lay public and also people that are involved in the schools and people that are involved in some levels of healthcare through simulation how to address common but diseases that have high impact, like the problems with delivery, like problems with arrest, cardiac arrest, and identify and treat those things early. So the trick is, or the question is, how do we do to bring this simulation at this level all the way up to what we have in our institutions in Boston? Do we need investment, we need the know-how to make this scalable, and we need the know-how to make these resources sustainable and reevaluate, find out how we can improve upon what we've learned and make this sustainable and scalable at this level. And that's about it. Any questions? So you don't need to be in a sim suite with cameras and with a double-side mirror being filmed to do simulation. As a matter of fact, last year we hosted in one of the meetings, the big meetings in the American College of Emergency Physicians, through the educational section of the international group, our meeting, it was basically called Simulation for Low-Income Settings. And just to put an example, what Dr. Bean explained, how to make ultrasound gel out of gelatin. There's a lot of different things that you can do to do simulation. Also, there's resources with cell phone technology as well that you can use. Easy to communicate, and there's all sorts of different values, like for example what Dr. Hall has done in Mexico with low-tech mannequins, right? And just teach the basic skills that are going to be able to at least save a life or to determine where to go next in those issues.
Thank you so much, Dr. Gutierrez. While we bring our next speaker up, I want to introduce Dr. Alfred Papali. Dr. Papali is a senior fellow in pulmonary and critical care medicine at the University of Maryland, where I work. He received his medical degree from McGill University, Faculty of Medicine in Montreal, and went to do his residency and chief residency in internal medicine at Georgetown in Washington, D.C. He also did a fellowship in global health through Mass General in Boston and spent time working in Sudan. His talk today is Telemedicine and mHealth, Life-Saving Technologies for Acute Care in Resource-Limited Settings. So Dr. Papali.
Thank you, Dr. Mulligan. Good afternoon, everyone, and thank you for coming to this talk. My name is Fred Papali. I'm a pulmonary critical care fellow in Baltimore. And today, I'd actually like to introduce you to several initiatives we've established in Port-au-Prince, Haiti. The new title of the lecture didn't quite make it in time for printing. So these are projects that I'm quite passionate about, and if scaled appropriately, I believe have enormous potential to impact the lives of critically ill patients around the world. So the image that you see here, I think, is quite typical of a low-income country and reminds most people in this room of kind of the things that we think about in relation to global health. Lack of access to healthcare resources, lack of access to potable water, to sanitation. These are underlying problems that contribute to disease in resource-limited countries. And understandably, a lot of funding goes towards trying to eradicate these major problems. But one of the things I've come to realize in my time overseas is that when somebody comes into the hospital, critically ill, barely clinging on to life, what matters most to me is what can I do right now to save that patient? What can I do right now to resuscitate him so that he can go home, or she can go home to continue providing for their families? And when I looked into this, I realized that critical illness is a major problem and a very underappreciated one around the world. 5 million people, estimated, die every year from accidents related to trauma. 19 million people die every year from severe life-threatening infections. Now, a typical ICU patient in a high-income country tends to be older, has multiple end-stage diseases that are less amenable to cure. But in low-income countries, people who are critically ill oftentimes are younger and have a new acute illness that presents in an advanced stage, and that illness is oftentimes amenable to intervention. So why critical care? It almost seems like an oxymoron to talk about critical care in resource-limited countries, because typically we think of ICU medicine as high resource and high cost. Well, the fact is that critical illness happens, right? Every single one of us, you, me, people outside, will all become critically ill at some point in our lives. Critical illness is not limited by language, it's not defined by political boundaries, it happens to us all. And also, critical care does not have to be expensive. The World Health Organization defines a very cost-effective intervention as, let me see if I can get this right, something that costs less than the GDP per capita per disability-adjusted life year. And when you look at global health literature on the surgical side, emergency surgery for trauma and for obstetrical complications falls well within these guidelines. And so extrapolating this, critical care actually is very cost-effective as defined by the World Health Organization. Also, the core principles of critical care are the same in Southeast Asia and Sub-Saharan Africa as they are in the United States. So cheap and effective interventions can actually be scaled to any geographic locale around the world. We believe we found a winning combination with our work in Haiti, and we'll call this resource-limited critical care. So the essential concept of really any global health intervention is that it has to be effective, it has to work, it has to be simple, and it has to be inexpensive. And these concepts apply to the 3 pillars of resource-limited critical care. The first pillar is education. In other words, training healthcare workers in acute care or critical care best practices. The second pillar is evidence-based medicine. That is developing protocols, data-driven protocols germane to resource-limited countries in order to reduce morbidity and mortality. And the third pillar is technology. In other words, leveraging existing facilities and existing resources and technologies in order to drive down, reduce the cost of care, and to improve the efficiency of the delivery of critical care medicine. We do our work in Port-au-Prince, Haiti, at St. Luke Hospital. St. Luke was founded in the immediate aftermath of the 2010 Haiti earthquake as a field hospital, literally tents in a gravel field. And over the past couple of years, it's developed into a beautiful campus and truly a world-class institution with brick and mortar structures, including this intensive care unit that you see there. St. Luke Hospital has been a pioneer in novel methods of promoting critical care education around the world. This website that you see, this is a screenshot of marylandccproject.org. This is a website that was developed by my colleagues at the University of Maryland. Every Thursday, we live stream several ICU lectures to Haiti and to the Dominican Republic. These lectures are freely available on the website to promote asynchronous learning. And our informatics guys tell us that we've had over 200,000 hits from 164 different countries in the past year. So clearly there's a voracious global appetite for critical care education. Websites are simple and they're effective. St. Luke Hospital has also been at the forefront of global health research. Last year, the physicians at St. Luke's were the first in the world to clinically validate the World Health Organization's protocol for severe sepsis and septic shock in resource-limited countries. Our results are actually going to be published soon, and I'm quite confident they'll make waves in the global health community once they are. Protocols cost nothing. They're very straightforward, and time again, they've been proven effective. Lastly, St. Luke Hospital has also been the site of a pioneering effort to develop an ICU consult service using the existing telemedicine program that we have at the University of Maryland. This program requires mobile technology, and in our case specifically an old iPad that was donated, an internet connection, and clinicians on either end of that internet connection. And so far, the physicians at St. Luke's have been able to call in consults when they felt like they were in over their heads. This has actually boosted their confidence because they know they have a backup, and also this has actually helped to hone their critical care skills. 2 minutes, gotcha, almost done. A natural extension of the tele-ICU program is a tele-ultrasound program that again has helped to boost the confidence of the physicians at St. Luke's. This program has used just mobile phone technology, an internet connection, and has allowed physicians in Port-au-Prince to communicate with physicians in Baltimore in order to discuss difficult cases and difficult images. And this service is available 24 hours a day. And just to drive home the point, this was actually a case in which I was involved. This was a young man who came in with abdominal pain, nausea, vomiting. The ER physician there actually scanned his belly and saw this. We weren't 100% sure. Took a quick picture on my cell phone, sent it to my colleagues at the University of Maryland, and within 5 minutes they said, yes, absolutely, this is an appendicitis. Get that guy open right now. So we referred him for emergency surgery. He lived. It's quite possible that he could have died had the technology not been there. So where do we take this? Obviously, we need more research, right? Our programs have been very successful on the local level, but we want to expand this to the national and hopefully international levels as well. But we can't do that without funding. So far, everything that we've done has come out of pocket. It's been tough on a fellow's salary to go down to Haiti, but I've managed to do it. And with that funding and with that research, then we can expand these programs to hopefully truly impact the lives of critically ill patients around the world. Thank you.
Okay, thank you very much. Thank you for your questions. There will be a little bit of time at the end of the session for some more questions if anybody has some. So I'd like to introduce our next speaker, Dr. Bradley Dreyfus. Dr. Dreyfus is an assistant professor of emergency medicine at University of Arizona College of Medicine in Tucson, and he serves as the director of global and rural health programs for the Department of Emergency Medicine. He's also on the board of directors for Global Emergency Care Collaborative, which is a 501c3 NGO focused on developing access to sustainable emergency care in Uganda. His talk is a model to maximize return on investment for emergency care training and service delivery. Dr. Dreyfus.
Good afternoon and thank you. I'm going to just take a gratuitous moment to ask how many people in the audience are not physicians? All right. How many in the business world? A couple, fantastic, and thank you for coming. Hopefully some of this makes sense. So as you can see, I'm going to be talking about return on investment for a different kind of training model for emergency care delivery. So my interests, conflicts, I have none. I wish I did. My objective is to convince you that increasing access to crucial emergency care services is necessary and has a large return on investment for long-term health security and economic growth. I want to provide a scalable model for integration of a mid-level training and service delivery into existing healthcare structures. So where are things headed? Right now, sub-Saharan Africa and Africa in general is being considered the place for the next big boom. If you look at the growth from 2002 to 2012, it outpaces the Middle East and North Africa as well as Latin America, both with GDP and direct investment. For those of you in business, I want to ask and have you speak up. What are your concerns about the threats? What are the threats you see to growth in this setting? Just throw out a couple, please.
Political instability.
War and conflict. Anybody else?
Currency devaluation.
Currency devaluation. All right, economic factors. True. What I think of as an emergency medicine doc is I think of infrastructure failing and having mass disaster because of it, right? Roads, looking at transportation that are not adequate for huge lorries or trucks, having airplanes and regulations that are not necessarily up to snuff compared to what we have in the West, and being cargo planes that are overloaded. Or having warehouses that were overstocked and end up collapsing, like what happened in Lagos last year. Another industry that is of pertinence right now is the petroleum industry in much of sub-Saharan Africa. There's a paper that just came out highlighting 28 different pipeline explosions over a 10-year period, with over 17,000 deaths and untold injuries and untold costs. So as we're thinking about development, what are the costs associated for companies to be developing with regard to insurance, with regard to not having the infrastructure they need? This is important because Africa has 9 of the 15 fastest growing economies in the world. It's not something we think about as physicians very often. And it's increasing, right? Growth rate went from 3.4% in 1990 to 2000 to 5.7 projected in 2015 to 18. With life expectancy going up, with school enrollment, so hopefully future students eligible for higher end jobs coming to market, and maternal and child mortality going down. So investment banks have taken notice, and the African Development Bank has a private equity arm, and they actually have some fantastic documents out there that outline their activities and what they're thinking is important. And they're really focusing on the developing middle class, right? Middle class, you end up having expendable income so you can actually have a consumer culture, which means those of you who are in business will actually be able to sell your wares, if you will. There's also been large investment in higher education, particularly for healthcare, because we're so far behind as far as having healthcare capacity. So, Terry, thank you very much for your thought about mangroves yesterday and the metaphor for emergency care. It's fantastic, right? It's a barrier. It's a barrier for all the inland structures, right? Hurricane Sandy, if New York had a bunch of mangroves, there wouldn't be billions and billions worth of damage. The surge would have been taken care of. In the same way, emergency care serves that purpose for a disaster, whether it be a biologic, like Ebola, with your surveillance that you would end up having, and treatment, or whether it be an earthquake, where you could actually distribute your injured amongst a system of emergency departments. Emergency departments are also great training grounds and serve a very, very important purpose for surveillance prevention as well. So to say acute care is a keystone is an understatement, holding the whole bridge up, and the bridge being the health system. Acute care is diverse. I will not go around the whole slate of services, but it's not just one part. So it functions on an economy of scale. Once people are there and the lights are on, it doesn't matter if we have 4 patients or 100 patients. It still costs the same for the system. It increases health security for disaster preparedness, like I mentioned, as well as injury surveillance prevention, and it reduces the industrial development costs and decreasing the magnitude of risk. Thinking about owning a business in a place where you have healthcare facilities nearby or where you don't in agriculture, your insurance risks are going to be lower where you do have healthcare services. And it buffers the impact and the downsides of people having expendable income with regard to road traffic crashes as well as non-communicable disease. So who can we train? Dr. Bean brought up the slide very aptly, thank you, that really describes the fact that there is very little in the way of physician bandwidth, if you will, for specialty and acute care. And even if there are physicians, they're in the urban areas, 80% of them. So the answer is task shifting. Sub-Saharan Africa, as we know, has 25% of the global burden of disease and 3% of the healthcare workforce. There's a huge shortage, which is concentrated in a small number of countries. And so the WHO in 2008 described task shifting to involve rational distribution of health worker teams, of tasks among health worker teams. Specific tasks are moved, where appropriate, from highly qualified workers to health workers with shorter training to make the whole system more efficient. So a case study is Global Emergency Care Collaborative, which operates out of Uganda, founded in 2007. And we work with local partners and train local staff to be mid-level providers. So essentially we use the pyramid of care focusing in the middle with the mid-level providers, also providing education to the physicians and the community members. So the reality is we're going to need to have emergency physicians trained, residency trained, to build this system to oversee. But then we're also going to have emergency care practitioners who are going to be working in the rural areas where we are not currently having any providers. So the course itself is 2 years. First year is both classroom and in-service training, very similar to an American residency program. It's symptom-based. Didactics, 40 to 50 hours per week of work, patient logs. We have both ultrasound and simulation built in, and the ECPs function independently. So just some pictures of our different parts of the program. We've been collecting data. We have over 30,000 patient visits worth, including injury surveillance, disease surveillance. Right now, we just put out a paper looking at case fatality rates for under fives. So if you want any of that data, I'm happy to provide it. I didn't have time to cover it here. Cost effectiveness. So the cost to train an emergency care practitioner in our model is about $9,000 for a total education of $13.3 thousand, as opposed to $50,000 to train a physician. If each is seeing 30,000 patients over a career, which is reasonable, the ECPs are less than half a dollar per patient. That's just for the training, and they're cheaper to employ. And you don't worry about the brain drain because they're locally licensed, not worry about them leaving. So over the next 12 to 24 months, we're expanding to a second site, which is a government hospital. We're going to be training 25 new ECPs. We're looking for funding to complete a randomized controlled trial. We have before and after for the second rollout site, but we're actively looking for funding to essentially put the nail in the coffin of the argument that acute care is too expensive. We're collaborating with the physician training program, and we're working directly with the Ministry of Health and of several universities so we can extricate ourselves. There's built-in obsolescence for us as Westerners helping facilitate this. So looking at scaling up, 80 districts, 1 national hospital, 11 referral hospitals, to staff 24/7, 365, all of them, is 423 ECPs. It'll take 21 years to achieve that at this rate, but we can scale up further. So a whole country covered by emergency care in 21 years. I challenge any of us to think of other systems that have worked that efficiently. Thank you very much. Any questions?
Okay, well, once again, we're ahead of time, but I would like to take advantage of this captive audience, and before I let you go, I want to have a small panel here of our collection of speakers, and I want to ask a couple different questions. So far, today we've seen multiple different examples of how emergency medicine and acute care is developing country after country after country. And as we see, emergency is I agree, more than just the care that's being provided by doctors in an emergency department. Emergency care and acute care is really about building a system. It's really about having this chain of care that goes from the point of injury or accident or incident all the way through to the return of the patient back to the community. The emergency department has been called a room with a view, the room that has this vantage point that doesn't exist in other parts of the healthcare system, where we can not only have a good understanding of patients who come in, patients who have communicable, non-communicable diseases. It's good for trauma registry. It's good for disease surveillance, and it's good for research and surveillance purposes. But it's also this room with a view where we can look back in time to how the patients actually got there and what are the problems in the healthcare system that caused the patient to come to the emergency department. We also have this ability to look forward in time to not just the hospital system, but to the rest of the healthcare system where we're going to have patients referred to and the public health system that the whole acute system exists inside. So what we're seeing is emergency systems being built country by country by country, not by having single or double interventions, but by building 30 or 40 small projects all at once that over time wind up interlinking with each other and then becoming the system that we're talking about. So what I want to just ask the panel, and then I'll open the floor to your questions. What have been some of the biggest barriers to building emergency medicine in lowest resource settings? And what are some of the ways that your experiences have gotten you either around or through those barriers?
I can tell you, I mean, I'm not an emergency physician. Is this mic working? Can you hear me?
You have to speak up a little.
Sorry. So I spent some time in South Sudan shortly after independence in 2011, and we built what I thought was a very promising program there through Mass General, and unfortunately it fell apart. And I think one of the biggest barriers that I found and my colleagues found was not something tangible, it was cultural. It was a lack of trust of the Western doctors coming in and kind of telling people what to do. And certainly that wasn't our intention, and we didn't feel like we were doing that, but there was this sense from our colleagues in South Sudan that we were there, call it medical colonization, if you will. So I think trust has been one of the biggest factors that I've run into, or lack thereof.
Mm-hmm.
Oh, it's a great question. Of course, there's lots of things. There's part of it that if you're thinking ahead, you're ahead of where policy is and where policymakers' thoughts are, which can be challenging of itself. You also have a lot of the funding agencies really being the tail that wags the dog, right? So you're in the meeting with some of the leaders in the Ministry of Health, and you're explaining how you could end up reducing their morbidity and mortality within their community by large amounts, but they're very focused on the vertical programs, right? When emergency medicine is inherently horizontal, supporting the vertical programs. And it's because they're funders who are saying, we'll give your ministry money to fund projects if you put it in line with what our priorities are and what our stakeholders want. It makes it quite difficult. So now there's a critical mass. I feel like a voice that says it's really important to have acute care and emergency medicine as fundamentally a health system strengthening intervention for a health system. Okay. That, and honestly, ego. I don't think a lot of the folks that we've been interacting with they're not used to being with folks, working with folks who are saying it's not about us, it's about the impact that happens over the long term. And we cannot wait to hand this off to the Ugandans. This is not, we don't see it as an industry. We're a bunch of academics who would rather move on to other things once we feel like we can rest well, knowing that the 5-year-old with malaria and the mother who just got hit by a car will get the appropriate care.
Okay. So I think there's one of the sub themes of this session today has been what is the interaction between the huge amount of growth that's happening in emergency and acute care system development and the social entrepreneurship and social impact network is there an overlap? Is there any crossover? And I think there is. I think there's a huge amount. What's happening in country after country are emergency systems are being built piece by piece by piece, and each one of these pieces has an applicability or an application to the social impact arena. And so I want to just draw our attention to those of you who are involved in social impact networks and in social entrepreneurship to keep thinking about emergency medicine and acute care. Most of the global burden of disease and public health indices are pointing towards acute care as being one of the next major global policy areas. So this is something I want to bring our attention to. I think we've run out of time. Are there any questions? Do we have time for maybe one question?
I actually just want to bring up, I want to go even a step further and say, for those of you in the more business end, we want to work with you. We have a lot to learn from you, and there's a lot of opportunity for collaboration to make what we're doing have that much more impact. Orders of magnitude, in fact.
Okay. Well, let's take a break. We have some coffee and our exhibitors outside. We're going to start back up again at 3 o'clock.